Good evening, everyone. I, Dr. Atul Dhingra, again welcome you in this webinar series on diabetes and its complications. We are going to discuss today about CV disease. I will not be wrong in saying that diabetes is indeed a disease of blood vessels. Either it is the small vessels which are involved, but the major morbidity and mortality is because of the large vessels that are involved with this disease. The most important cause of mortality being CV disease, and this is what we are going to discuss today. And for this, we have with us a very senior consultant endocrinologist from Bombay, Dr. Rohit, joining us today. Dr. Rohit is currently working as assistant professor in endocrinology at KEM Hospital. He did his MBBS from CMC Vellore and then pursued his MD again from CMC and DM from KEM Hospital, Bombay. He has multiple publications in various national and international journals, and he's also speaker at various national and international conferences. Welcome, Dr. Rohit, for today's webinar.
Thank you, sir. Thank you for the kind words of introduction. I'm looking forward to this full discussion today.
So we can start with today's presentation.
Diabetes and cardiovascular disease, partner in crime. As Dr. Atul sir has clearly explained before, diabetes is a disease of vasculature gets affected in diabetes, and that is most common cause of morbidity and mortality in diabetes patients. So now we can see these figures are increasing as the days go by. Prevalence of diabetes is about 10% among patients who are aged more than 20, and we are the second largest in the world who are living with diabetes. And in India, 1 in 11 live with diabetes. For a population such a huge population in India, these numbers are really overwhelming. To add on to this, when we talking about morbidity and mortality and the complications because of diabetes, then the disease burden is huge when we look at Indian scenario. 90 million people, adults, are living with diabetes. 1 in 2 adults with diabetes are undiagnosed, and 747,000 deaths caused by diabetes alone in 2021. Now, what about cardiovascular disease? According to International Diabetes Federation, the prevalence of coronary artery disease among diabetes population is 2.5%. Studies have shown that about 65% of diabetes die of cardiovascular disease, of which nearly 80% are attributable to coronary artery disease. Now, when we look at Asian Indian patients, our genetics and our makeup is very different from Western population, where the mortality after a single acute coronary event is 40% higher in Asian Indian patients. When we look at diabetes and cardiovascular disease, the Framingham Heart Study, which was the large cohort study which looked at the risk factors and the outcomes. When we look at single risk factor, the odds ratio was about somewhere like 2-3, but when the risk factors start adding up 2-3-4, the odds ratio increases exponentially. It has also been seen that the cardiovascular disease is more in women, whereas the stroke was more in men in this Framingham Heart Study. What are the risk factors for cardiovascular disease? As we started this presentation saying, the vasculature is the center point for all the comorbidities in diabetes. What happens is there is a state of insulin resistance, because of which there is increased free fatty acids. Finally, what it does is there is increased a very bad milieu which happens in the body, because of which what happens is there is lot of inflammatory markers in the body, increased CRP, etc. Finally, we know that the work of striatum gets activated and there is increased chance of thrombosis. So this again explains the pathogenesis of cardiovascular disease in diabetes. That is, lot of hyperglycemia, oxidative stress, epigenetic changes finally leads to increased inflammatory markers, increased free fatty acid. So all this milieu finally leads to poor vasculature, that is endothelial gets affected, because of which patients can have morbidity and mortality because of coronary vascular disease. Now, how do we prevent? Now, we know that by the large studies which were conducted, the UKPDS and DCCT, we know that glycemic control has very good is of prime importance to reduce the metabolic memory and to reduce the comorbidities. So it can really be delayed or prevented by controlling your blood pressure, control your blood glucose, cholesterol, and lifestyle measures such as smoking, eating unhealthily, and increased physical activity will delay your diabetes associated cardiovascular disease. Now, when we look at primary prevention, involves preventing or delaying new onset cardiovascular disease in patients with type 2 diabetes, whereas your secondary prevention involves treating patients who have already had an established CVD. So when we look at therapeutic strategies, most important is glycemic control. And now with the newer therapeutic modalities which are available, one of the combination therapy which targets the ominous octet can help in achieving glycemic goals earlier, and maybe we can preserve beta cells for future. Your DPP4, SGLT2, GLP-1 array have revolutionized the therapy of diabetes, especially your and GLP-1. So what SGLT2 and DPP1, this combination is unique. Where your SGLT2, what it does is it mainly acts by causing glycosuria, because of which they have pleiotropic effects. But one problem with this is you can have urinary tract infection or fungal infection in the urine. What DPP4 does is it acts as an incretin, where GIP1 increases. Finally, what it does is it has got a lot of beneficial effect, which has indirect effect on the pancreas from SGLT2, whereas where it is increased beta cell sensitivity and increased glucagon, and your DPP4 increases insulin secretion. So this combination, if, as an FTC in Indian patients, is helpful because it is safe, rapid, and hypoglycemia chances are less. Insulin resistance is improved and beta cell function was also improved. It reduces body weight, especially SGLT2, pill burden, overall cost effective, and additional benefit is they've seen that the urinary tract side effects such as UTI are a little bit less when this combination is used. When you look at cardiovascular benefits, there are various trials. There is paradigm shift which has happened after this SGLT2 inhibitor was introduced. The declared TIMI, to start off with, declared TIMI 58 showed that dapagliflozin was non-inferior to placebo when we look at primary safety outcome of MACE and significantly lower cardiovascular death or hospitalization for heart failure. So this comes to the end of the discussion. So I've given an overview of cardiovascular disease and diabetes. I think we can discuss further how to approach and manage these patients.
Thank you, Dr. Rohit. Overview of CV disease in patients with diabetes. So there are a few questions for discussion for the sake of our viewers. So you did talk about pathophysiology of CV disease in diabetes. How does insulin resistance and endothelial dysfunction, the interplay between these factors, result in CV complications, especially in diabetic patients?
Yes, sir. The interplay is very complex as we understand as of now. What happens is your insulin resistance. Because of insulin resistance, there is unhealthy milieu which is there in the body. An insulin resistance patient, as we know, it will be a little bit obese. Already there is dyslipidemia because of bad your LDL, and all this LDL will be more, and because of insulin resistance, there's a component of oxidative stress which is happening. So all this finally leads to your endothelial damage, and because of that, there is deposition of your LDL and plaque formation and the coronary vascular disease, to name a
Yeah.
few mechanisms apart from others.
Yeah, absolutely right, Dr. Rohit. How does atherosclerosis in a diabetic patient differ from a non-diabetic patient, whether it's the age or the patient's weight? How are these two distinct in diabetic versus non-diabetic patient?
Yeah, see, diabetic atherosclerosis, because the disease is widespread, there is more vessels which are involved in a diabetic patient, and the progress also is more rapid in a diabetic patient compared to a non-diabetic patient. They say that when they approach the coronaries, multiple coronaries will be affected in diabetic patients, and not only your coronaries, your peripheral vascular disease, your say central nervous system also is affected in diabetic patients. Is more commonly affected than your non-diabetic patients, is what I understand.
I agree with you, Dr. Rohit. And what we see is that our patients are diabetic patients are younger, and of late I work in a center where we have cardiology services, and what I have seen is the age is getting even more younger now. I am frequently being called for managing diabetes in a CCU where my patients are around 30-35 years and they are undergoing primary PCI. So I believe the age is getting younger, and that is something we need to ponder about, I
I
believe.
totally agree with you, sir. The age, I think it has reduced by 2 decades, is what I feel. What used to happen at 50, now we are seeing at 25, even 20, 30
Yeah, you're right.
diabetics coming with cardiovascular disease.
Recently, yesterday, I saw 39-year-old female who underwent PCA. So that was even more surprising for me. So she had,
Because when we were studying in our earlier days, they used to say that younger
uh,
patients don't even suspect cardiovascular disease.
yeah,
But now it's the other way around.
it's
Any
the other way
any
around.
patient at any age, any
It's can,
cardiovascular, please
yeah,
suspect and
have
rule
to
it
be on
out.
you. There is nothing like, there is no dictum that a young patient will not be having
Yeah, yeah.
coronary event. Don't do an ECG in that. So it's now our routine that we always do an ECG and then we proceed. We have talked about pathophysiology. How important is lifestyle interventions in managing these patients, especially what I believe is that the lifestyle intervention should begin early in a patient's lifespan rather than once he has developed diabetes, and then this is what I feel. And what are your what is
Sir,
your thought
I
on
concur with whatever you're saying, sir. I feel that the most important factor for primary prevention is lifestyle, is what I believe. Your diet and lifestyle, especially healthy diet, healthy eating habits, maintaining your weight, physical activity, should be part and parcel of your life. And as you have a healthy lifestyle, the chances of you getting into a coronary event or your coronaries getting damaged will substantially reduce. But once you start, definitely after once you become diabetic, once you start, that will definitely help. But you're losing out on a lot of benefits of the healthy lifestyle.
So I recently started doing yoga, and when I started doing it, I felt, why was I not taught this when I was in my first standard or second standard? And I asked my kid's principal that you should introduce yoga and it should be a part of curriculum, and it should be a subject that a student has to pass. That this is the number of yoga asanas that you have to do in this grade, and then only you will be passed. So I believe this is what is required at community level. If we are able to implement this, these things were there in our culture, but off late we have stopped. And once you start doing it, then you understand the importance. It's really a good thing. So what are the challenges that you face in implementing cardiovascular risk assessment? I work in a private practice, and every test has a cost to it, because more than 90% of my patients are paying out of their pocket. Even to ask them to get an ECG done is sometimes a challenge for me. How frequently do you do ECG, echo, or other tests in your patients?
Sir, the way I see it, one is the patients come for a specific reason. They are coming to you to control sugars. When you start
Well,
telling
yeah,
them that you are at risk for cardiovascular disease, then
they don't want to
sometimes
listen.
they take it back. So,
Yeah.
if some patient has any definitive risk factor, they're okay, exertional and other classic symptoms, then I push and I somehow get it done. But these regular patients to get a regular evaluation done, it's definitely a challenge, especially in a when you practice in a metro and all, when people are pressed for time and etc. So but it's a big challenge. But once you give them data and then tell them that diabetics are definitely more prone for cardiovascular disease, somehow you have to have some innovative ways where you can do on the spot ECG etc., where facilities are available, where they don't waste much time. Those are some of the ways. Or put the numbers in the cardiovascular risk calculators and tell them this is what is happening. So those are some of the ways how I motivate. But definitely it is a challenge when somebody comes for some reason and you start telling them about something else. I think I'm sure you must also be facing the
Yeah.
similar
So
issue.
how? Yeah, exactly same. So how frequently are you using these cardiovascular risks? So I've been trying to use QRisk
Yeah,
list, but it becomes challenging when the OPD
yeah,
gets. So
I
it becomes
agree, sir.
challenging to fill those
Yeah,
all
I
these
totally
and
agree, sir. I totally agree. It's
so
definitely a challenge, but some of the patients where it is necessary,
we
somehow
can
it makes some time. Otherwise, routine checkups and all, we have to explain to them. That's the only way to go, I feel.
Are you using anti-pro-BNP for the primary, picking a primary patients who are not who have not come to you after a coronary event, or who are not symptomatic at that time? Are you doing anti-pro-BNP as a preventive marker, or as a marker of CHF?
In a few patients, I have done NT-proBNP because they were having some cardiac related issues where I was suspecting. But I feel the cost and the
Yeah,
that becomes a hindrance. But I've
yeah,
used in a few patients. Some of my cardiology friends, they routinely use when I,
yeah.
because what happens is when it comes from their mouth, patients are little more
Patients are able to get
concerned.
it. Yeah.
So
So
what? Yeah,
it's cost in my OPD, the test cost somewhere around 2,800 to
yeah,
3,000
yeah,
rupees.
yeah.
So it becomes really difficult to
Yeah.
convince, especially
Yes.
asymptomatic. So if he's having dyspnea and he's clearly in CHF, then yes, he'll get it done. And you're saying it correctly, that if my cardiologist colleague is saying, then there are more chances that the patient will get it done. We see a lot of patients with CKD in our OPD, and CKD is one of the most important. Microalbuminuria is one of the important risk factors for development of CAD. So, what are the implications in management when you see a CKD patient? How aggressive you are in finding coronary disease in these patients, and how do you manage these
Yeah,
patients?
CKD, once I find that patient is going into CKD, then I become very aggressive because now that's once a CKD sets in, because another risk factors are added on. And once you have a CKD, then you already know that another microvascular complication has set in. And we all know that once a microvascular complication is set in, CKD especially, then there is a high chance that you are going to have some sort of a cardiovascular morbidity associated with it. So one is pushing those patients to get the evaluation done, especially in these patients. Second thing is management wise, get their glycemic control, and then adding the newer drugs like SGLT2 in this group. But in them, telling them that you really have to get into your diet, lifestyle, glycemic control, and evaluation, because in them, I mean, we cannot really give a choice to them saying you have a choice. You just get it done and then come back to me. That's the way I do. Now, how about you, sir? KD.
Yeah, absolutely. If CKD is, I also try. I also become more aggressive in these situations. We do evaluate them for presence of CAD. We make it a point that at least once in a year, once EGFR is less than 60, we get at least once a year we get an echo done, and we try to convince these patients for NT-proBNP, and we try to get their ECG, and we try to calculate the risk score in these patients. We find any symptoms, then we do refer these patients to our cardiology colleagues for further work. We have talked about lifestyle modifications. Comments on management of diabetes in the situation. You have a patient who is at high risk of developing CAD, ones who's already developed CAD, ones who has CHF. So what, or one who has stroke, for that matter. So how do you manage these patients?
So in these patients, definitely because they already have complications, your glycemic control should be on board. We want the glycemia to be as normal as possible, less than 7%. But having said that, if the organ dysfunction is too much and they're old, then little bit of relaxation of glycemia, considering that they already have CHF and all, should keep. Otherwise, glycemic control with whatever means is possible in the patient, especially if creatinine all is okay in these patients, then try to use all the drugs which are available, especially use SGLT2 inhibitors in these patients, and if needed, insulin as much as possible and to control their glycemia. But SGLT2 definitely on board. Now, if they're obese, then we can think of GLP-1 RAs, which can reduce weight and definitely add on to the patient's advantage. Some of the strategies which I use, where most important is glycemic control, because some way I feel that adding on these new drugs, we lose track of glycemic control. We are okay with HbA1c of 10%, 11%, but we are adding these new drugs. But I don't know whether it might be counterproductive. So definitely these newer drugs are very helpful, but keep a close watch on glycemic control, and then you make sure that your statin and your aspirin, they're on board. If they already have a cardiovascular event or primary prevention, then aspirin, if they have very high risk factors, that's when we try to add, or statin if they are more than 40, 45 years, then we try to calculate the risk again if possible. Otherwise, control the HD, LDLs, and then diet and lifestyle, as I said. Anything else, sir, you would like to add?
Yep, absolutely. I agree with you, Dr. With this is what we do also. We also do in our OPD. Just for the sake of our viewers, do you believe that all the glyphosins are similar, or do you compartmentalize these glyphosins that in CHF I'll use more of DEPA, in post CAD, post my MI I'll use more of EMPA, or the economics is the major driving factor for you for choosing a particular glyphosin?
Yeah, I feel that all the glyphosins, I mean DAPA and EMPA especially, which are available, they work similarly, but the trials at trial data they've used in different scenarios. So because of the availability and the cost, I think DAPA will be the first line in these patients, because you can use them in heart failure, you can use them in CKD, you can use them in all the things. And in EMPA, definitely it is the first drug which was used in your heart trials, EMPA-REG, etc. So DAPA would be the preferable because of the availability, cost, and trial data available. And because DAPA works, then EMPA I use in very specific, or any sparingly I use is what I would put it. How about you, sir?
So yeah, DAPA is the molecule that I am using most commonly. Like you also said, economics is one of the reasons. Uh, I do tend to use EMPA in patients who come to me post myocardial infarction, or those who have had an event. So this is a situation where I use. In CKD patient, I tend to use more of DEPA. So, like you, like your practice, I also am using more of DEPA, and some of my patients are on. Cana is very less. Cana is so. How do you ensure compliance? And in my OPD, the most difficult thing is to make my patient compliant for statins. If my patient is above 40, I do tend to write a statin to him, but they'll get a cholesterol report done from any lab, and they'll show me that, see, the cholesterol is the report is showing it's normal, so I have stopped it. This is what happens in my OPD very commonly. So how about your patients?
Similar,
How do you
similar, sim-
ensure
yeah,
compliance?
similar scenarios, because I feel that patients are they're they're more concentrated on controlling their diabetes, and they're not looking at all these other complications we should also control. What some strategies I use is I try to use minimum pills as much as possible. So try to use some combinations, and I usually avoid afternoon, because usually working population they skip the afternoon this thing. So morning and night, somehow try to squeeze your meds, morning one and night one, and somehow, unless it is needed, don't try to use afternoon also. Then it becomes an additional burden. So these are some of the strategies I use, and I mean I tell the patients to use some pill box or some reminders, and some of the motivated patients too. But some patients they find it difficult. Them we have to keep on motivating. It's a challenge.
Yeah. So yeah, this is what I see. I also see. So they tend to take the medication where either it is associated with improvement in a symptom, or they are able to see an improvement in their parameters. That medication they will continue to take. Like statin is one of the medication which doesn't lead to any change in patient's day to day life. The patient doesn't feel any change. So I think that is one medication that is stopped most commonly. So
I
yeah,
agree,
you're
sir.
right. Education, I believe, is the
Yeah,
key.
because and then there are a lot of things they read up, statin induced diabetes. So then there again they try to stop statin, etc. So again and again telling.
We talked about economics. Like I was telling, more than 90% of my patients are paying out of their pockets. In Rajasthan, we have government programs where our patients are provided with free insulin, statins are available, ARBs are available, SGLT2 inhibitors are available. So many of my patients who show me in my private OPD, they do tend to get their medications from Rajasthan government's schemes, and many of my patients are also purchasing medications from these the government funded or medical shops that are now routinely available in all over the country. where they have uh, generic medications. So, what is your take on this? And we'll also like to know the programs from Maharashtra government. Are your patients also getting free medications from government?
Yeah, yeah. Maharashtra government, like Rajasthan government, also is giving free medication and free insulin in some patients, etc. And there are definitely these generic shops which are available. It all depends on the patient's preference. Some of the patients they want to try out generics, and in some of the patients are happy because it works. But in some of the patients, what happens is it may not work. So I tell the patients saying you can try it out. There's no harm, but we need to have some results. That's the way I look at it. So if your sugars are controlled, then because at the end of the day patient is it's a chronic recurring expenditure for them,
Yeah.
so they are trying to reduce and something like that. But if the sugars are not controlled and all that, then I tell them you have to be careful with these medicines, or you have to switch to whatever gives you good control. How do you tackle this, sir?
You're absolutely, Dr. Rohit. Dr. Rohit, we talked about patient education. So, what are the strategies that you use in your OPD? How do you educate your patient regarding the link between diabetes and CVD? So, what are the methods that you use?
The best what I realized is in patients, when you give a lot of information in one sitting, patient usually forgets or misses out, or they may not understand. So giving some little bit of information at every visit re-emphasizes whatever you're trying to tell. And I usually ask them if they've understood or explain in their own words. Those are some of the strategies I use, first of all, to make sure that they understand what we are seeing, and giving some examples of some of the patients you have managed without taking the names, obviously with anonymity. If you can tell them saying this patient would come and then patient's sugars was uncontrolled, patient landed up with MI, so you be careful. Some of these light things which are live examples, then patient can't relate with them more commonly, because then they'll have some relative who's had an MI. So then it links to them, because when I tell them a lot of theory, then I tell them that diabetes can cause cardiovascular disease. Then they say, "Ah, sir, we know all this, and everywhere it is there." But when you give them examples that of patients you have seen or something like that, so some of the live things which I think it will be more impactful for the patients is what I feel.
Absolutely right, Dr. So, we also what we have done is we have pasted some posters in our waiting area, where we have tried to tell them about the relation between diabetes and its complications. So, some of my patients read those posters, and when they had a consult time with me, they did talk about CV disease and diabetes control. So this is one thing that we use in addition, and in some of the patient it does. Thank you, Dr. Rohit. It was very nice talking to you in this webinar. So before signing off, a take-home message for our viewers.
Diabetes, don't take diabetes lightly. If you control diabetes well, I think you'll have a long and healthy life, because once the complications start, then there's no turning back. Primary prevention, or if you've had a complication, then don't let another complication creep in. These are all easily doable. It just requires some amount of discipline and some consultation, and simple measures can take it a long way. Any message from you, sir?
Thank you, Dr. Ray. So, like you said, diabetes is a disease which, if managed with discipline, you can have a long, comfortable life with it. And you have to be aggressive right from the beginning. You need to take care of your lifestyle measures like exercise and your diet, and routinely checking for CV disease once your doctor prescribes it. It also makes a difference, because if we catch the disease in a subclinical stage, probably we'll be able to prevent it. And like you told, newer medications like SGLT2 inhibitors and GLP-1 receptor agonists are now available, which have shown promising results in this. So again, thank you, Dr. Rohit, and it was a pleasure talking to you. And we had some good discussion today, and I believe many of our viewers will be benefited with this.
Thank you, sir, for moderating the session so nicely, and we had a very meaningful and Very good discussion, which I'm sure will help the viewers. Thank you, sir,
Thank
once again.